goal of treatment for me is to reduce or diminish inflammation as early and as effectively as I possibly can. My belief is that even at best when we treat MS early and effectively, some people will still progress, but I believe that the likelihood of progression and the speed of progression are diminished by early effective treatments. In terms of what I want to do, I want to modify the disease. Modifying the disease means to reduce inflammation as early as I can, reduce the likelihood of attacks or relapses as early and completely as I can, and by so doing, reducing progressive disability.
One of the important transformations in the MS field relates to the expectation, both in terms of people living with MS as well as care teams and their treatment. We used to consider that someone who has MS and is on one of the first-line immune therapies would experience a decrease on average in new MS activity and injury by about 30–40%. Now that we have many more treatments available, including much more effective treatments, the bar is set higher. We realize also that there's a great extent of injury that occurs under the surface, and we've become as a community much less tolerant of injury to the CNS. And the axiom time is brain is very appropriate in this context. And anything that we can do to proactively limit new injury and ideally stop it completely in individual patients has now become the preferred approach of most clinicians following people with MS. Our goal ought to be to individualize treatment. A term commonly used nowadays is precision medicine. It recognizes that people are different. People are different in terms of their immune background, and then you superimpose on that a condition like MS, which itself is very heterogeneous. We need to recognize that treatments can differ both in terms of how much impact they will have on new MS activity in an individual person, as well as the potential risk of any given treatment in a particular individual. Our goal, and the community is moving forward in this regard, is to be able to identify in individual patients which is going to be the most effective as well as the safest treatment for them to be on.
I began treatment in treating MS early in my career before there were any disease-modifying therapies. The first disease-modifying therapy entered the market, entered the United States in 1993. I began practicing before 1993, and as such I saw a number of people over more than a decade who had no effective disease-modifying therapy. Their outcomes in my practice, their outcomes when looked at in epidemiologic studies were much worse. Most of us are really grateful that even though we haven't perfected our treatment of MS, we're so much further along the line than we were. I think we do treat earlier. I think we do treat more effectively. I think we do get less progression.
Treating early is a very important concept in multiple sclerosis. We know that now from multiple clinical trials that had designs that included a delayed initiation of treatment. So one arm might start the treatment earlier, the other might start it in a delayed fashion. Those who delay initiation of multiple different treatments never catch up. They develop disability that persists and is built upon without it being reversed. So we are still a ways away from fixing things that are broken within the central nervous system, and the imperative nowadays, which is a very real one, is to stop, to limit as much as possible in individual patients any new injury. The earlier that we can do this, and as long as we can do this reasonably safely, the better.